This is the case of a very bad pseudophakic bullous keratopathy that was operated on with a Gunderson flap about a year ago for the pain that the patient couldn't manage anymore with contact lenses and lubricants. So we did the lysis of the flap, and we're starting our DMEK in a routine fashion with the inferior PI, checking the inferior PI with the vitrector retropupillary, and then we're stripping the whole of Descemet's from Schwalbe's line to Schwalbe's line under air. Now the patient seems to have had a bit of vitrectomy because there's no posterior pressure and the air is passively resting in the AC with no tendency to leak out. As is often the case in bad bullous keratopathy, Descemet's membrane strips off easily, is thick, doesn't rip, and comes off in one piece, and sometimes has very vigorous attachments to the old phaco wound or side ports. In this case, there's a strong attachment to the phaco wound at 12 o'clock that requires coaxial forceps to disengage. The decision to do a DMEK rather than a PK in this case was made on pre-op OCT. We saw no significant scarring, and it was just our impression that the patient would do fine with a PK. So we're injecting the graft. I believe it's a 9mm graft, and the chamber is deep, further confirming our suspicions that the patient is indeed vitrectomized. Now we're injecting jets of BSS to try to get the graft to open up a bit, and then we're aligning it with the main wound and using the cannula inside the rolls to inject some air bubbles. This is the very well known bubble in the roll technique, where you inject one bubble inside the roll to get the graft to lay on top of the iris so you can get the orientation. And here a positive Mutsuri sign is observed, and then with the help yourself maneuver, the graft is nudged in the nasal angle. Now we're injecting another bubble underneath the graft, which proceeds to displace the bubble that was placed anteriorly. And now the graft is up against the cornea, but not well centered and kind of rolled up. So we're injecting BSS to reduce the size of the bubble that is underneath the graft, and then using the coaxial forceps we drag the graft over to a more central position. Then we managed the small bubble that was hanging on in the nasal angle. Further manipulation with the coaxial forceps are required in these deep eyes with large grafts, especially as is shown here, the graft got stuck in the inferonasal angle and direct manipulation is required, but a few of these will not hurt the overall endothelial population of the graft. And the final step of the procedure is always the final airfill, which in this case occupies all of the AC. So thanks for watching.